All right, so seems like I got disconnected, and so I'm going to pick it up one more time. So here we are. We were on meiosis 1 and prophase 1, that stage of meiosis 1. What we are looking at here is that the nuclear envelope has disappeared, and you have these two centrioles forming on one on each side. And most importantly, something happening here. You see that the mom and dad's homologous chromosomes that we talked about before, they have come together, and something called crossing over has taken place, which means chunks and pieces of one chromosome, like from mom, has swapped places with the dad's chromosome. So you see that uh, there's like a mixture of red and blue segments, right? Originally, dad's chromosomes were all colored blue and mom's chromosomes were all colored red. But now you see that after crossing over, there's this random haphazard intermixing of different segments of the chromosomes. In other words, nobody knows if mom's brilliant green eyes went with dad's short height or dad's high IQ went with mom's being overweight. So all kinds of characters get shuffled up here, all right? So this wonderful process called crossing over results in mom and dad's chromosomes swapping genetic chunks randomly, haphazardly. So this is kind of like a shuffling of cards, right? Even though you have the same deck of cards every time, but when you shuffle them and then pass them out to the players, every time you get a different combination. This is exactly what it is. So what does that mean? You are basically a mixture and a shuffled up, genetic shuffle up of all of your ancestors, both from your maternal and your paternal side. All right. So it's not quite as simple as, oh, you get trace 50% from mom, 50% from dad. It's never quite that simple. And anyone can see that because even them, they are made up of bits and pieces of these haphazardly, randomly put together pieces of the entire lineage from their mom and dad sides. And so that's who we are as sexual reproducers, as meiosis people. We are these randomly mixed genetic pieces of the lineages from both mom and dad side that came before us. So crossing over, that adds a whole lot of shuffle up and uncertainty to this genetic mixture. And this happens during prophase 1, okay? Also notice, well, let's move on to the next stage first. Now this one says metaphase 1. So remember, metaphase, the word starts with M. You can think of that M as for middle as well. So what happens during metaphase 1 is your crossed over mom and dad's chromosomes line up in uh, in pairs in the center of the cell. You see they're lining up, but there's two of them, right? There's so two files. They are lining up in two files, and at the same time, the centrioles send out these feelers, kind of called spindle fibers, and the spindle fibers attach to the midpoint of each of these chromosomes. All right. Then comes anaphase 1. The word anaphase starts with the letter A. You can also think of that letter A as denoting away or apart, because what happens now, as you can see in this picture, is those spindle fibers are pulling the chromosomes apart to each pole. This set of chromosomes goes here, and the other set of chromosomes goes to the other side. All right. Now, before I go any further, remember how we were lining up in the middle during metaphase 1? Something else happens here, which is our equivalent of a genetic lottery or genetic shuffle up. So you see how these chromosomes are lined up here this way? It could just as easily have been this one could have been here and that one could have been there. Or this one could have been here or that one could have been here, right? So how many pairs are we looking at here? 23 pairs. So this line goes on all the way down to 23 pairs, right? Each one is lining up quite independently of how the other ones are lining up. So all kinds of these arrangements are possible. And this is something called independent assortment, okay? Independent assortment or independent alignment. Okay, alignment or assortment. Okay, and this happens during metaphase 1. Um, Crossing over took place during prophase 1, right? Okay, So why does it matter? The independent alignment, like which one is lining up where? Because that adds further genetic diversity. Because when the cell divides, now you never know which cell is going to get this pair, which cell is going to get that member of the pair, right? It's all haphazard. So independent assortment adds another layer of genetic uncertainty to the sperm or the eggs that are eventually going to form, just like, much like crossing over. Okay, anaphase one, they get pulled apart to each side. Then comes telophase one. And T for telophase, T for two. They separate out. The parent cell is separating out into two daughter cells, each with a unique combination of chromosomes, thanks to crossing over and then independent alignment. Cytokinesis, when the cell splits into two, okay? But we are not done. This is only meiosis one. Next comes what? Next comes meiosis two, okay? Let's get there. Here it is, meiosis two. So in meiosis 2 as well, you have the same substages, prophase, metaphase, anaphase, and telophase, only they have this denomination here, 2, the Roman numerals 2. So this is the second one time. Okay, so what happens during prophase 2? It's not quite as eventful as prophase 1. So no crossing over happens here, but you still have the nuclear membrane dissolving. You have the two centrioles forming on the two sides. And then metaphase 2, same. M for metaphase, M for middle. They're lining up in the middle. But notice what? Now they're single file because they already split during the first. So they were already two cells, right? So now they're lining up single file, not double file because they already split before. So single file in metaphase 2. Then anaphase 2, again, apart, away, A for away, A for anaphase. Now these sister chromatids get pulled apart to each side. So each chromosome is made up of these two sister chromatids, and these sister chromatids get pulled apart during anaphase 2. And then again, telophase 2 and cytokinesis, uh, each cell divides into two further cells. So how many do you end up with at the end? Four daughter cells. Each one has half the number of chromosomes, or the haploid number of chromosomes, 23 only as compared to the parent cell. And each one carries a completely unique genetic combination of chromosomes. What a beautiful process, right? Sometimes this happens, non-disjunction, which means what? The chromosomes or the sister chromatids do not separate out properly. So an extra chromosome, if you will, sneaks into one of the eggs or one of the sperm. Okay, so you have gametes, which means either sperm or eggs with either 22 chromosomes, which is one less, or 24 chromosomes, which is one more. Sometimes that happens. And the older the age of the mom or dad at the time of conception, the higher the chances of non-disjunction. So aging itself is a risk factor for non-disjunction, especially things like Down syndrome, trisomy 21. This is what it is. What trisomy 21 or Down syndrome is, you have an extra chromosome sneaking in at pair number 21. So instead of having a pair, you get triplet, three chromosomes. That is Down syndrome. And we all know what Down syndrome individuals look like. They have these slanted eyes, thick tongue, thick neck. They also have to have an IQ which is lower than the average population. They're more prone to have like heart defects and those kinds of things, okay? So that's called trisomy. Tri means three. So on pair number 21, instead of two, you have three. Or you can have one less, which is called monosomy. So instead of 46, you end up with 45 chromosomes. Generally speaking, monosomies are more lethal, more dangerous than trisomies. Trisomies can usually are born and they can survive to relatively normal ages like Down syndrome. But monosomies like Edwards syndrome, Patot syndrome, all right, these are some examples. They rarely, they're either a stillbirth or even if they're born, they don't really make it to a ripe old age. Most of them die before reaching 4 years of age. All right, so Down syndrome, we talked about that one. Major risk factor, mother's age. So after age 35 years, this risk of delivering a child with Down syndrome goes significantly higher. Okay. How do sex chromosomes differ from autosomes? Autosomes are similar, both mom and dad's chromosomes, same size, same shape. Sex chromosomes can either be homologous, XX, that makes you a girl, or a sex chromosomes could be an X and a much smaller Y, and that would make you a boy, all right? Remember, the Y chromosome is much smaller than the X chromosome. Why do gametes have to be haploid instead of diploid? Because haploid means they only have half the number of chromosomes. So you have 23 in the sperm, 23 in the eggs, When they come together during fertilization, you get 46, which is the normal number. If you had 46 to begin with in the sperm and the eggs, when they come together, 46 plus 46, that'll give you 92 chromosomes. That's not a human embryo. In what ways do mitosis and meiosis differ? We talked about those differences. What is the difference between sister chromatids and paired homologous chromosomes? Sister chromatids make up each chromosomes, but eventually they separate out, and each sister chromatid then is considered a chromosome in its own right, and each sister chromatid will again sprout uh, another sister chromatid. So that's what a chromosome is. Chromosome is two sister chromatids together, and each sister chromatid is eventually, after it separates out, will again become a chromosome and sprout another sister chromatid. What is independent assortment? We talked about that. This happens during metaphase 1. Each pair of chromosomes lines up quite independently as to the other ones. What is reduction division? That's another name for meiosis. Why is it called reduction division? Because you reduce the number of chromosomes from 46 to the haploid number 23. At what point does in meiosis do the daughter cells become haploid? At the what stage is that? That would be during metaphase, rather anaphase, uh, anaphase 1, right? Anaphase 1 is when they become haploid. So here we are looking at the female reproductive system in a sagittal section from the profile. Okay, so probably the organ that you notice the most is right here, the uterus, right, or the womb. Let's see. Okay, there. So, right, and so you would be right to notice the uterus. It's a fleshy, smooth muscle-rich organ, pear-shaped and pear-sized organ in its non-gravid, non-pregnant state. It can obviously enlarge much more during pregnancy. And this is anteverted. It's facing kind of anteriorly and superiorly, as you can see, right? Uh, all right, then uh, the uterus lies on top of the urinary bladder. That's the urinary bladder. And there's this little space in between the uterus and the urinary bladder called the vesicouterine pouch, right here, vesicouterine pouch. So when a woman gets pregnant and the uterus starts to expand, get bigger, this would definitely squeeze down here on the urinary bladder and make the woman feel this urge to urinate. And that's why pregnant women need to urinate that much more often. So from the urinary bladder, you can see the urethra passing out to the outside, right? Anteriorly here, uh, you have a lot of fat in an area called the mons pubis, which literally means the mouth to the pubis, right? Also called the mound of Venus. A lot of fat here to prevent like injury to this area during copulation and things like that, right? You have pubic hair. Um, this is the pubic symphysis right in the front. You also see some of the abdominal muscles, like your six pack, right? The the oblique muscles and then the transversus abdominis muscles over there. Here is the clitoris, okay? And the clitoris is the most sensitive region in the entire human body, male and female both, right? Because, well, males don't have it, but like, I mean, the most sensitive organ overall, because this little area has no less than 8,000 sensory nerve endings, okay? For comparison, the male glans penis only has 4,000 sensory nerve endings. Clitoris has over 8,000 sensory nerve endings, making it exquisitely sensitive to any sensation, right? Uh, and this is also the only organ in either sex, male or female, whose sole purpose is sexual pleasure, nothing else. The clitoris is simply there to enhance the sensation. That's all it does. All right. So then moving back here, posterior to the uterus in the back, you're looking at your colon, all right, the rectum actually, which is the terminal part of the colon, and then the anus right here, anal canal. So again, pregnancy and your uterus expands, so it also puts pressure on your rectum. And that explains why some women tend to get constipated when they're pregnant, again, because of this pressure here. They also might feel this urgency to go to the bathroom to defecate for the same reason. It's all about the pressure changes that have taken place here. What else are we looking at here? Because that's also part of your large intestine, okay? Uh, in between the uterus and the rectum is the rectouterine pouch here, also called the pouch of Douglas. Rectouterine pouch. This one was vesicouterine pouch in between the bladder and the uterus. Okay, there's your ovary. Okay, the ovarian tube. And then here you are looking at the fallopian tube. This, it almost looks like a hand with the fingers. These fingers are called the fimbria. This region is called the infundibulum of the fallopian tube. Then here is uh, the infundibulum, then the ampulla of the fallopian tube. This is where pregnancy takes place, which I mean fertilization. This is the very first place there where the sperm meets the egg, right here, okay? All right, so you're looking at the ovary, the ovarian tube, and then the fallopian tube and the fimbria, the hand-like structure. So these fingers, they kind of suck up the egg, which is released by the ovary inside of them. And so then the egg proceeds through the fallopian tube into the uterus. If the sperm is present, sperm is introduced through the vagina, of course, right here. So it climbs all the way up. Here's your vagina. Here's the cervix, right? Cervix is the entry to the uterus. It goes into the uterus, the sperm that is, then the sperm climbs all the way up into the fallopian tube, and the egg, it will meet the egg released by the ovary halfway, more than halfway, all the way here into the ampulla. This is where pregnancy takes place. When you talk about a tubal pregnancy, that happens mostly in women who smoke a lot. Smokers are more likely to develop it. Why? Because smoke, the cigarette smoke tends to damage the little hair-like cilia which are found throughout the fallopian tube. The cilia are beating to move the egg towards the uterus. If they stop beating, then the egg moves very slowly. The sperm has already fertilized it. It has turned into an embryo. The embryo doesn't have enough time to get all the way down and implant itself into the uterus. Rather, it implants itself here in the walls of the tube, and that's called a tubal pregnancy. Here, you're looking at a real cadaver. Looks like an elderly female, and an actual autopsy is what you're looking at, right? Or a surgery. Mons pubis, lots of fat in the region. Here you're looking at the urinary bladder. There's the uterus. You see the uterine tube. The two ovaries are visible. Those are the finger-like fimbria over the ovaries, right? You can also see the broad ligament of the uterus in this picture. We'll talk about that before. And you see the round ligament that's around the fallopian tubes. So all of those structures are visible in this picture as well. All right. So let's take a look at some of the other structures in the female reproductive tract in an anterior view from the front. So the most obvious organ, obviously, here is the uterus, okay? The uterus continues downwards into the cervix. This area is called the os cervix, okay? Uh, the os cervix right here. And then the external os. And here is your birth canal or the vagina, as you can see, okay? Uh, then what else are you looking at? You are looking at the two ureters, okay? And the ureters, remember, again, carry urine. They're taking urine from the kidneys down to the urinary bladder. Okay, here is a connective tissue called mesosalpinx, which is part of the broad ligament of the uterus. The mesosalpinx, which protects and surrounds the ovarian tube here, and it also attaches to the fallopian tube, okay? These are the two ovaries, ovary 1, ovary 2, right side and left side. And then this is the fallopian tube. This is the fimbria, infundibulum, uh, ampulla, and the isthmus of the fallopian tube. You see it in the picture, okay? All right, then what? So here you're looking at something called the suspensory ligament of the ovaries because it suspends the ovaries, the suspensory ligament on both sides. The suspensory ligament contains the ovarian artery and the ovarian vein, which supply the ovaries again, as the name suggests. Then you have this big drape-like peritoneal cover called the broad ligament of the uterus. The broad ligament of the uterus, not surprisingly, carries the uterine artery and the uterine vein. You see those structures here in this picture as well. So this gives you a good idea of what the female reproductive tract looks like, okay? All right. Now let's take a look at what's happening inside of the ovaries here in this picture. All right, so here you're looking at the uterine tube, right? Lots of smooth muscle within the uterine tube for obvious reasons. It has to move the egg through it. And then, of course, here's the lumen. This is the mesosalpinx, the connective tissue protection for the uterine tube, which carries arteries and veins, the broad ligament of the uterus, mesoovarium, a part of the mesentery that supports the ovary. Here is your ovary, and the ovary uh, has a type of epithelium called the germinal epithelium at the time, at the outside, and it's called germinal epithelium for obvious reasons. It gives rise to the germ cells, which would be eggs, as you can see. The outer area here is called the cortex, and this is the medulla, the middle part of the ovary. Also, what you see in this picture, importantly, is the egg itself developing. And you see that the egg goes through different stages of development: primary oocyte, secondary oocyte, and then mature oocyte. It literally looks like an egg if you look at the whole thing. Here's the egg cell, though, in the middle, okay? So again, a cross-section of the ovary. And you are, well, what type of an epithelium surrounds the ovary? A cuboidal epithelium, something else to remember, cuboidal epithelium. Okay. And you're looking at the egg or the oocyte in its different stages of development. All right. So a young female is born with many of these primordial follicles, immature eggs, if you will, right here, right? Then the primordial follicles mature into primary follicles like these, okay? Primary follicles mature into what are called secondary follicles, okay? And how's this maturation taking place? At the time of puberty, under the influence of the FSH, follicle stimulating hormone, which comes from your anterior pituitary, under the influence of the gonadotropin releasing hormone from higher up in the hypothalamus, that causes the maturation of these follicles that contain the egg cell. So under the influence of FSH, secondary follicle then matures into the mature follicle, also called the Graafian follicle. Graafian follicle or the mature follicle. Now you see the egg is ripe and ready to burst. Then under the influence of the luteinizing hormone or LH at the time of ovulation is when this follicle bursts and the egg is released, right? This is ovulation in action that you're looking at. So what happens to the follicle, the empty follicle after the egg has been released during ovulation? It turns into this little structure called the corpus luteum, from lutea, which means yellow. So it literally means the yellow body. You see it's like yellowish in color. The corpus luteum sticks around for another 2 to 3 weeks. If there's no pregnancy forthcoming, then the corpus luteum breaks down into this whitish structure called the corpus albicans, from alba, which means white, okay? If pregnancy takes place, then the corpus luteum is maintained. It keeps secreting estrogen and progesterone, the female sex hormones, to maintain the pregnancy for the first full trimester, and then it dies out, okay? Right, so these are the stages of the different follicles and egg maturation in a female. Each female is born with about 1.5, 1.5 million primordial follicles present at birth, okay? Then these primordial follicles mature into primary follicles, as we see here, which have cuboidal cells, all right? They secrete estrogen as they mature. So here, you are looking at primordial and then primary follicles. Then come the secondary follicles. Secondary follicles have two types of cells on them. The thecal cells, which secrete male sex hormones, interestingly, or androgens, which do get converted into the female estrogen hormone by the granulosa cells. So here you can look at the secondary follicle. Here are the thecal cells that secrete androgens or male hormones, which will eventually get turned into estrogen, the female sex hormone, by the granulosa cells. And you also see the egg is surrounded by this glycoprotein layer called the zona pellucida. The zona pellucida surrounds the egg, as you can see here, okay? So then becomes the antral follicle. The antral follicle derives its name from the term antrum, and antrum is a fluid-filled space, as we shall see here. This is all fluid. So this bluish stuff. So when the fluid starts to fill up the follicle, then it's called the antral follicle. The antrum is this fluid-filled space, as you can see, okay? All right. So then the antral follicle finally matures into the mature or the Graafian follicle, as you can see. And this one contains a fully mature egg called the secondary oocyte, okay? The secondary oocyte has chromosomes which have completed meiosis 1. So they're ready to go into meiosis 2. They're arrested or stopped or standing still in the second meiotic metaphase. That's where they're still at, okay? And so how many mature follicles does an average human female form per month? Only one. Rarely she could release two eggs, and that results in non-identical twins when those two eggs get fertilized by two different sperms. So we'll get into that as well. And then finally, after ovulation and the egg is released from the follicle, the empty follicle turns into the corpus luteum, which means the yellow body. This secretes both estrogen and progesterone. The purpose being, if pregnancy were to happen, the estrogen and progesterone from here will help the uterus prepare for that pregnancy. If no pregnancy happens, then the corpus luteum breaks down into this whitish corpus albicans, okay? And this just gets resorbed in the body, okay? So the thing to remember, by the time that an average human female reaches puberty, she has about 400, she was born with 1.5, 1.5 million primordial follicles, but by the time she reaches puberty, only 400,000 follicles remain in the ovaries. The maximum number of ovulations or eggs that a typical human female can release during her reproductive time span is 400, no more than 400 eggs, okay? All right, so next up we are looking at the ovarian cycle, okay? And the ovarian cycle has three phases, as we see here: the follicular phase, the ovulatory phase, and the luteal phase. Here, those are the three ones, okay? And when does the cycle start? At the time of puberty, under the influence of gonadotropin releasing hormone from the hypothalamus, and the FSH and LH from the anterior pituitary. So let's take a look at each in turn. So what happens during the follicular phase? First up, follicular phase is from day 1 to day 13 of a 28-day menstrual cycle. So the first 13 days is the follicular phase. Why is it called the follicular phase? You would have guessed. This is the time when the follicles are developing, right? So around 20 primordial follicles are selected and they're stimulated to mature into primary follicles under the influence of FSH primarily and also LH, okay? All right, so the follicles get larger, they fill up with fluid. Now they're called the antral follicle, because antrum, again, remember, is the fluid-filled follicle, okay? So now the primary oocyte, which is your egg inside of the primary follicle, at this point, it finishes meiosis one and it forms two cells, okay? One of these cells is called a polar body. And this polar body is just going to just dissolve away, okay? It's non-functional, as you can see. The other cell that came out, this is the primary egg now, or the primary oocyte. The other cell derived from the primary oocyte. Now this one is relished and great care is devoted to it, and it gets a lot of cytoplasm and it becomes larger. And now this one becomes the secondary oocyte, or the mature egg. And this goes all the way to metaphase 2 stage of the meiosis, and then it stops at metaphase 2. Okay. Now, if a sperm does fertilize the secondary egg at this stage, then it finishes the entire meiosis. It goes on from metaphase 2 to anaphase 2 and then telophase 2, if fertilized. If it's not fertilized, then the secondary egg breaks down in 24 hours and passed out with menstrual blood. That's what happens, okay? So from the follicular phase, now we are talking about the ovulatory phase, ovulation. This takes place at mid of the cycle, day 14 of a 28-day cycle. And why does ovulation happen? Under the influence of a surge of luteinizing hormone from your anterior pituitary. So the LH, or the luteinizing hormone, causes ovulation, okay? Antrum increases in size and swelling, and then the follicle bursts, releasing the secondary oocyte, or the mature egg. So what happens after the ovulatory cycle is something called the luteal phase. Why? Because the empty follicle that is left behind turns into corpus luteum, and the luteal phase goes from day 15 to day 28 of the cycle, okay? And the corpus luteum is basically, you can think of it as a temporary endocrine gland, because it's releasing the sex hormones estrogen and progesterone, trying to prepare the uterus for possible implantation in pregnancy, okay? But if pregnancy is not forthcoming, then corpus luteum breaks up into, or rather breaks down into corpus albicans. All right, so then What happens to the corpus albicans? It is shed out during menstruation. Okay, that's the end of the luteal phase when menstruation happens. First age of menarche between ages 11 to 12. It's progressively dropping, as I mentioned, especially in African American females, as low as 9 years now. Okay, so here you can looking at you can look at the ovarian cycle in a graphical form, uh, and what happens during the three stages: the follicular phase, the ovulatory phase, and then the luteal phase. So menopause is when a typical human female stops uh, menstruating. The ovarian cycle stops, takes place between 45 to 55 years of age, and some a little earlier and some a little later. It's pretty genetically determined. And so what happens with menopause is now they're not releasing estrogen and progesterone from the ovaries. So that has some health consequences, like the bones thin out. Bones need these sex hormones, estrogen and progesterone, to stay thick and sturdy. So osteoporosis, weak, porous bones that are likely to fracture become more common after menopause. Okay. Okay, so if pregnancy does happen, then what happens? The embryo starts releasing a hormone called HCG. This is the pregnancy hormone, by the way, that you might do the urine test for. HCG, human chorionic gonadotropin. So what human chorionic gonadotropin does is it causes your uterus to become thick and fleshy and ready for the pregnancy, to maintain the pregnancy, right? And it also continues to uh, uh, it basically inhibits further ovulation. So you don't menstruate when you're pregnant, right? Because the HCG tells your anterior pituitary to stop secreting further FSH and LH at that point. All right. So let's quickly take a look at a uh, rather common uh, gynecological cancer here, namely ovarian cancer. So the ovarian cancer is kind of like an insidious malignant process, which means it doesn't have many signs and symptoms to begin with, or has very vague ones, and that's what makes it uh, extraordinarily dangerous as compared to the other cancers, some that tend to give us early indications, right? What are some of the risk factors for ovarian cancer? A family history, having a first degree blood relative who has suffered from it, being obese or overweight, being on a fatty diet, uh, you know, some genetic mutations that might happen haphazardly in people. So all of these are risk factors, okay? And the vague signs and symptoms that you might have at times: abdominal cramps, abdominal pain, a sense of fullness, loss of appetite, nothing that would really point to the ovaries, okay? It's the fifth most common cancer in women, and a high index of suspicion is necessary for the diagnosis, okay? You may look for things like some blood tumor markers, such as something called CA125. This is a blood marker which is markedly elevated in not only in ovarian cancer, but uh, other types of cancers as well, like liver cancer, uterine cancer. Uh, but this is one of the things, non-specific blood markers that can be used to look for ovarian cancer. Again, having a first degree uh, blood relative, that is a big risk factor. So you should have a high index of suspicion. Treatment, again, is chemotherapy, radiotherapy, and if needed, surgery. What are the broad ligament, ovarian ligament, and suspensory ligament of an ovary? The protective coverings. How are the primordial, primary, secondary, antral, and mature follicles similar? They are all the different developmental stages of the follicles. How are they different? We talked about those. What ovarian follicles are present at birth? Primordial follicles. What ovarian follicles are present at puberty? Uh, Primary and secondary follicles. What are the specific effects of FSN and FSH and LH on the ovarian cycle? FSH is active during the follicular phase, causes maturation of the follicles. LH is needed for ovulation. What are the three phases of the ovarian cycle? Follicular, ovulation, and luteal. And what main events occur in each phase? We talked about those, all right? Okay, so next up, we are looking at the fallopian tubes here, okay, and the uterus. So let's go ahead and take a look at those structures here. All right, so first up, cervix. Uh, there's the cervix, and this is kind of like the mouth to the uterus, which is right over here, okay? Here is the fibromuscular canal, or the birth canal known as the vagina, which opens up through the cervix into the uterus, okay? Now, the uterus itself is quite a fleshy, thick muscular organ, and it has three different layers to it, right? An inner endometrium, and the endometrium is the layer that actually sheds out, right? Columnar epithelium that sheds during the time of menstruation. Then the thickest of all is the myometrium, this thick, fleshy, smooth muscle layer, and then an outer perimetrium, which attaches the uterus to the surrounding organs, okay? Here you're looking at the fallopian tube. These are the different parts. This is the uterine part of the fallopian tube. This is the isthmus. This is the ampulla, and this is where the fertilization takes place. The sperm and the egg meet here, and then this is the infundibulum, which has these finger-like fimbria surrounding the ovaries. Here are the two ovaries, as you can see here as well, okay? All right, and then of course the supports to these organs, the round ligament of the uterus, the round ligament of the ovary, you got the broad ligament of the uterus, you have the suspensory ligament of the ovary. So we have looked at all of those before as well. We also talked about tubal pregnancy, what can cause it, and what are some of the risk factors um, attached thereto. All right, let me just quickly make sure we didn't miss anything out. All right, so yeah, these are the different parts of the uterine tube, right? The infundibulum, ampulla, isthmus. You have simple ciliated columnar epithelium here, muscular layer, tubal pregnancy, we talked about that. Now, the real risk with tubal pregnancy is it will burst if allowed to carry on for any further than 8 weeks of development. The embryo gets large enough to the point where it will actually rupture the tube, and then this rupture can lead to life-threatening hemorrhage and peritonitis. The infection spreads everywhere. All right, then the uterus, we talked about its functions, the different parts. All right. We talked about uterine and vaginal prolapse. It's more common in overweight women who are multigravida, have given birth repeatedly. The three layers of the uterus, again, endometrium, perimetrium, and myometrium. The birth canal here. All right, so another clinical picture that you're looking at here is something called endometriosis. What does that mean? Simply the presence of uterine endometrial tissue in a place outside of the uterus, okay? Like on the ovaries or on the fallopian tube or sometimes even the rectum or the large intestine. That's what endometriosis is, the presence of functional endometrial tissue any place outside of the uterus, okay? And how do you know that you have it or you might have it? Signs and symptoms, extreme cramping and pain during your menstrual cycle, excessive bleeding, uh, high index of suspicion. Again, first degree blood relatives who have suffered from endometriosis. How do you diagnose it? And endoscopy, right? So you need an endoscope to visualize the insides of your reproductive tract. And if bleeding uterine tissue is found elsewhere outside of the uterus where it should be, that's diagnosed as endometriosis. Sometimes this can also be found buried deep within the smooth muscle of the uterus, and that condition is called adenomyosis, okay? Adenomyosis is a subtype of endometriosis where the tissue is found buried deep within the smooth muscle, the myometrium of the uterus. So again, excessive bleeding, cramping, all of those things could be associated with endometriosis. And then another quite intriguing disease uh, entity which is associated with endometriosis is something called chocolate cysts. And as appetizing as the name might sound, it is anything but, right? What are chocolate cysts? Endometrial tissue found on your ovaries, surrounded by the ovarian capsule. So where does this name come from? Why chocolate cyst? Because since this endometrial tissue is embedded within the capsule of the ovary and under the influence of the menstrual cycle, when the hormonal levels fluctuate, this tissue bleeds as well, just like your normal endometrial tissue bleeds. But since it's confined within the ovarian capsule, this blood gets trapped inside of the ovarian capsule, and the blood breaks down over time to this chocolatey, gooey, syrupy consistency. If you look at the ovaries, they literally look like they are filled up with chocolate. So therefore the term chocolate cyst. It's a type of endometriosis involving the ovaries. The treatment, again, surgically you can remove it. You can also burn it surgically using a process called cauterization. Okay. Now you can also give hormonal treatment like birth control pills. They also help with the severity of the disease, as you can see here. Sometimes surgery is all that is needed. So cervical cancer, again, a rather common uh, gynecological cancer, some risk factors: early age of menarche, late age of menopause, multiple sexual partners, early age at the time of initiation of sexual activity. All of these factors make your risk higher for developing cervical cancer. Interestingly, there's a virus called the human papilloma virus, or HPV, especially strains 16 and 18, infections, chronic infections with which have shown to increase your risk of cervical cancer, which is kind of unusual because usually we don't think of viruses or infections that give you cancer. Cancer is a non-infectious disease entity. But in this case, HPV infection can actually cause mutations within the DNA of your cervical cells, giving rise to cervical cancer. How do you get diagnosed for it? A pap smear. A pap smear is when a doctor is going to take scrapings from the cervix and look at these cervical scrapings, tissue, under the microscope to see if there's any uh, mutational changes in those cells. All right. If positive, then you go to the treatment modalities that include surgery. Sometimes the entire uterus is removed, called a total radical hysterectomy, or TAH, along with chemotherapy and radiotherapy. All right, so here we are looking at the 28-day uterine cycle, and this coincides with the ovarian cycle. All right, these are not like two separate things. Ovarian and uterine cycles are going on hand in hand. All right, again, timeline is based on a 28-day cycle. The first 5 days are called the menstrual phase of the uterine cycle because that's when the menstrual blood flow is taking place. Then comes the proliferative phase of the uterine cycle. That is from day 6 to day 14. And it's called proliferative phase because your uterus is proliferating, it's getting thicker um, uh, in, 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 in size and shape, right? So let's see what stages of the ovarian cycle coincide with this. So the menstrual phase will coincide with the late luteal phase of the ovarian cycle, right? The proliferative phase coincides with the follicular phase of the ovarian cycle. The secretory phase coincides again with the luteal phase because it happens from the day 15 to 28 after ovulation, post ovulation is when this happens. All right, so again, those three: menstrual phase, uh, proliferative phase, and then secretory phase is the last. So what are the four segments of the uterine tubes? Infundibulum, ampulla, isthmus, and the uterine part of the uterine tubes. Fertilization takes place in the ampulla. How does each of the three tunics of the uterus contribute to its function? Endometrial layer is the one that basically where the pregnancy is implanted, and also the lining which is shed during menstruation. Myometrium is why you feel the cramps, or during childbirth, the myometrium, the smooth muscle of the uterus, contracts to push the baby out. Perimetrium surrounds and supports the uterus. What are the main functions of the vagina? It's the birth canal, the baby passes through it. It's also the organ that receives the penis during sexual intercourse. It's also where menstruation flows out from. How does its structure support these functions? It's a fibromuscular tube, it can distend. What are the three phases of the uterine cycle? We just talked about them, right? Menstrual phase, proliferative phase, and secretory phase. What events occur? We talked about that. Compare and contrast the ovarian and uterine cycles. We talked about those as well. All right, next up, we are looking at the female vulva, which means the external organs of the female reproductive system. There's the mons pubis, the mound of Venus. lots of subcutaneous fat and pubic hair surrounding that area. Here is the clitoris. We talked about that organ before, right? The clitoris is hidden under a hood, which is a layer of skin that surrounds it, okay? Uh, and the more erect it gets under sexual stimulation, the more it retracts under the hood, okay? So you cannot appreciate the full length of the organ, basically. Then you have this area called the labia majora, or the major lips. This is the homologue or homologous to the male scrotum. The male scrotum and the labia majora are homologous organs. Uh, Inner to the labia majora, and there's a lot of sweat and sebaceous glands in this area, right? Also apocrine secretions. So pheromones, if you will, are secreted here. Then the inner, more delicate lips called the labia minora, which are pink because of good blood supply here. And then you have moistening glands here called the Bartholin's glands, all right? Or vestibular glands as well that secrete mucus under sexual stimulation to aid in the whole sexual intercourse process, right? Here's the vaginal orifice, okay, for the extrusion of menstrual blood to receive the penis, um, childbirth, all of those happen here. Then here's the perineum, the diamond-shaped area, and the anus. So you can see, and here's the urethral opening. So clitoris at the very top, then the urethral opening for urination, and then the vaginal orifice, right? So this is the order from superior to inferior in which these orifices are arranged. So in the females, the conduit for urine is quite different from the conduit uh, for the child, all right? In males, the penis carries both urine and semen. So here you can look at the deeper structures which were not seen in the other picture, right? So here is your pubic bones. This is the pubic symphysis, clitoris, the body of the clitoris, right? There's the crus of the clitoris, which the muscle, remember, called ischiocavernosus, which causes erection of the clitoris, as you can see, right? And then the greater vestibular glands that secrete mucus for lubrication. No, also remember that there is something which has been called the female prostate. All right, and the female prostate are basically called skin glands. Skin glands, also labeled as female prostate. And so these glands have their own secretion, and sometimes these secretions can squirt out, like during sexual stimulation. And so they have been dubbed the female ejaculation at times. And for the longest time, there was a question as to what that liquid really is. Is it urine? Is it secretion of the Bartholin glands? Uh, it's actually from the Skene's glands, the so-called female prostate. All right, next up, we are looking at the female breast, which is part of the accessory reproductive system organs, right? And of course, the function is to produce milk, like in all mammals, to feed the child. And so we are going to look at the different anatomical features of the female breast. All right, so it's a fibrofatty tissue, okay? Fibrous and fatty tissue. As you can see, lots of fat here. These are uh, collagenous suspensory ligaments that hold the breast in shape. Here are the lobes of the breast. Each one has many lactiferous glands and lactiferous ducts that carry milk towards the nipple. The nipple is surrounded by this darkly pigmented area called the areola. The alveoli are the milk-forming glands, all right? Alveoli are the milk-forming tissue or glands that you have in the female breast, as you can see here. So again, you can see all of those structures, the suspensory ligaments, the lactiferous ducts that carry milk produced by the alveoli towards the nipple, as you can see here, okay? Lactation means release of milk, which happens uh, when the child starts to suckle at the breast. The hormones involved in this are two. Prolactin, which is secreted by the anterior pituitary under the stimulation of the child, the infant sucking at the breast. The other one is oxytocin, which is secreted by your posterior pituitary. It's synthesized by your hypothalamus, but stored and released by your posterior pituitary, okay? So what prolactin does is it causes synthesis and secretion of milk. But oxytocin actually causes what is called the let down reflex, which means the milk is actually expressed out of the breast. So you need both. You need prolactin and you need uh, oxytocin as well, let down reflex, okay? So what you have to do is you have to put the child to the breast frequently. You have to maintain this schedule so that your positive feedback as regards lactation is maintained using oxytocin and prolactin. Okay. So here we're looking at some of the contraceptive methods or birth control methods, all right? The only one that is 100% foolproof is abstinence, abstaining from sex altogether, but not very practical for a majority of people. So then we come to the rhythm method, which means avoid time, sex or sexual intercourse or unprotected sexual intercourse during the ovulation time. So how do you know when you're ovulating? You can keep like a basal body temperature chart. So usually 2 to 3 days surrounding ovulation is when your body temperature basically drops about 1 to 1.5 degrees Celsius. There's a drop in body temperature, which indicates ovulation. But again, this is kind of like pretty much guesswork. The failure rate of the rhythm method is more than 25%. Withdrawal method, again, not the best, where you pull out the penis just before ejaculation. Almost a 20% failure rate, again, because of self-control issues. Some sperm can still escape even before ejaculation. Live sperm, that is. Barrier methods, quite effective. Condoms, female condoms, also called diaphragm, right? Gels, spermicidal gels. If used correctly, they have a over 90 to 95% success rate. They also protect against a number of STDs, sexually transmitted diseases, if properly used again. All right, lactation is a physiological method of birth control because when you are lactating, uh, so the high levels of prolactin prevent follicle stimulating hormone and luteinizing hormone secretion, so they prevent ovulation. You can also use IUDs or intrauterine devices like the copper T. That's a famous one, right? And so what the intrauterine devices do is they are like metallic implants or other implants put into the uterus. They fool your brain into thinking that you're already pregnant. Something is impacted in the uterus, so it prevents ovulation. Same with your oral contraceptives, which are usually estrogen progesterone combinations, right? So the high levels of estrogen and progesterone contained therein within the oral contraceptives trick your brain into thinking that you're already pregnant. So they prevent ovulation, okay? All right. And then morning after pills, same thing, they inhibit ovulation and they're effective up to 72 hours after sexual intercourse. You can also take certain prostaglandins like mifepristone, and this causes miscarriage if used during the first 7 weeks of pregnancy by causing your uterine muscles to contract. Tubal ligation, where you basically snip the ovarian tubes, the fallopian tubes, and tie the ends, and that way the sperm never complete their journey to the egg, okay? Or vasectomy, this is in males, right? It's a male birth control, and both of them are irreversible for all practical purposes. Remember that. So before you undergo either tubal ligation or vasectomy, you have to be pretty sure that you're not looking to expand your family, okay? So vasectomy is the same thing. You cut out the ductus deferens, the vas deferens, and so that way the sperm are never ejaculated out of the body. But this does not interfere with the testicles' intrinsic testosterone production or sperm manufacture. Breast cancer, the most common cancer in females. 1 in 8 women, the incidence is increasing. Look at some of the risk factors, a family history of breast cancer in your first degree blood relatives, obesity, high fat diet, right? Genetic mutations such as BRCA1 and BRCA2 mutations. So Angelina Jolie, the famous actress, she's possibly the best known advocate uh, of mastectomy. So she apparently inherited the mutated version of the BRCA1 gene from her mom, which means that she had up to an 80% chance of developing ovarian and breast cancer or breast cancer by about age 60, right? So therefore she chose to undergo an elective uh, double mastectomy, got both of her breasts removed, and so that brought this mutation into public consciousness for the most part, right? All right, so the greater the estrogen exposure to the breast, the higher the chances of developing breast cancer. In other words, the lesser pregnancies that you have had, the more unfertilized ovulatory cycles that you have gone through, the heavier you are, the more fat in your body, the higher your risk for breast cancer. Giving birth and frequent pregnancies and breastfeeding are protective against breast cancer, as you can see here, okay? Mammography is what is needed to screen it at age 50 and later on, because what is a mammogram? It's a simple x-ray, plain x-ray, which will show uh, these nodules in many cases, right? But the rate of false positives is quite high as well, especially if done in younger women, because there's so much fat tissue there that can interfere with a true positive result. So here we are looking at the sexual response cycles of both males and females. This was extensively studied by Alfred Charles Kinsey, the famous sexologist in the 1940s and 1950s, and then his work was expanded upon by Masters and Johnson in the late 1960s, early to late 1960s. And so they came up with these different sexual response cycles, which are very similar in males and females. It starts with the excitement phase, which is when sexual thoughts or sexual stimuli cause primarily pelvic vasocongestion, which means blood flow to your pelvic region, to your genitals increases, which results in an erection in males and females both, red blushing of that area, also the mucus secretion picks up, nipples become erect, uterus becomes more erect, as you can see. Since we are talking about the female response here, the vaginal wall starts to constrict, the blood pressure and the heart rate and the respiratory breathing rate all increase, right? And then the excitement stage progresses into something called the plateau stage, where the heightened sexual excitement is maintained at that level, and then that results continuous sexual stimulation results in an orgasm, which, as it says here, is an intense uh, release of pent-up sexual energy. There's an orgasm is basically an event in the brain, more than the genitals, right? So if you are studying the brain using a PET scan, what you would see is that there is a flood of hormones, especially dopamine and oxytocin. They flood your brain. So, and these are your pleasure hormones, your feel-good hormones. Oxytocin also promotes bonding and the love feelings, right? Dopamine is the feel-good, the rush hormone. So both of them peak in the brain at this point. And then rhythmic contractions of the vagina and the uterus for several seconds. And interestingly, both male and female orgasms show about the same rate of rhythmic contractions of the genital area, which is about 0.8 contractions per second. Okay, so it's remarkably similar in both sexes per second. All right, and then that is followed by the resolution phase, where all of these changes, the pelvic vasocongestion, the increase in heart rate, blood pressure, respiratory rate, they all regress, they all revert to their normal baseline position, and intense relaxation, and a lot of people go to sleep at that point as well, uh, again, because of the high levels of oxytocin. So what are the individual components of the female external genitalia? We talked about the labia majora, labia minora, mons pubis, clitoris, vaginal orifice, all of that. So, and their functions. Relationship between lobes, suspensory ligaments, and lactiferous ducts. We talked about those too. Lactiferous ducts convey milk to the nipple. Suspensory ligaments hold the breast in place. Lobes are the different fibrous partitions in the breast uh, for making milk, basically. What are the effects of prolactin? Prolactin causes milk synthesis. Oxytocin leads to the let down reflex, the expression of milk from the female breast. What are the three phases of female sexual response? Excitement. Uh, they didn't talk about the plateau here. So excitement, orgasm, resolution. All right, next up, we are looking at the male reproductive system. So again, um, let's take a look here in a sagittal section. You're looking at the male reproductive system. The male gonads are the testicles, or the testes, a pair of them. You can see them here, suspended in a thin sac of skin called the scrotum, suspended outside of the body for good reason, because sperm are highly temperature sensitive. So they need to be kept at a cooler temperature than the rest of the body. So the temperature in the scrotum is about 1 to 2 degrees Celsius cooler than within the abdomen, and that is needed for the shelf life and the vigor of the sperm, as you can see here. Right behind the testes, you see this highly convoluted tube called the epididymis, which stores the sperm and also nourish them and lead to their maturation. The epididymis then uh, climbs up here, at which point it's called the ductus deferens or the vas deferens. Then it climbs up into the pelvis and makes this loop here. At this point, the ductus deferens is joined by a duct from your seminal vesicles, these pair of glands here, and then it's called the ejaculatory duct. Then the ejaculatory duct passes through the prostate gland, which is right here, and then carries onwards as the male urethra throughout the body of the and the length of the penis, as you can see here. Okay. Now, at this point, let's talk about the three accessory sex glands in a male. So, the prostate, right over here, a walnut-sized, walnut-shaped gland that surrounds the male urethra with very important implications that we will talk about here shortly. Then the pair of seminal vesicles that secrete, what do they secrete? Fructose and prostaglandins. Fructose is the energy source for the sperm, the fruit sugar, fructose, and the prostaglandins help the sperm on their journey and also help the sperm uh, stimulate the female reproductive tract for the reception of the sperm, okay? And then you have a couple of uh, what are called Cooper's glands. Cooper's glands or bulbourethral glands, and they secrete an alkaline mucus to lubricate this entire passage of the sperm to make it easier, okay? So those are the three accessory glands. It's important to know each secretion. Oh, we didn't talk about the prostate. Okay, so first up, well, the seminal vesicles. What are the two secretions from there? Fructose and prostaglandins. Fructose for sperm nourishment, prostaglandins to make the female reproductive tract more hospitable to sperm. Okay, then the pair of bulbourethral glands, they secrete alkaline mucus for, why alkaline? To neutralize the acidity of the female vagina, because the normally acidic female vaginal pH would kill the sperm. So the alkaline mucus prevents that. It neutralizes the acidity, but that also gives a chance for microorganisms to make the journey, as we mentioned before, honeymoon cystitis during this time into the female reproductive tract. All right, so the prostate gland here. Now the prostate secretes three important secretions, something called seminal plasmin, which is kind of like an antibiotic. This prostate's very own antibiotic to prevent infections, seminal plasmin. Then it secretes a protein called PSA, and we talked about that one before. It's an important marker for prostate cancer, prostate-specific antigen. And what this protein does is it causes liquefaction of the semen. The semen congeals first, it clots, and then it liquefies so the sperm can swim further into the female reproductive tract. And the third secretion from your prostate gland is citric acid. Then the citric acid is again for nourishment of the sperm. Okay, what else? So if you look at the body of the penis, these are the two erectile uh, or tissues here. That is something called the corpus spongiosum, which is dorsal on the top, and then you have a pair of corpora cavernosa or singular corpus spongiosum. Both of these cavities are spongy and they can fill up with blood under sexual excitement. And when the corpora cavernosa, I switched the two. The ones at the top are the corpora cavernosa. This one surrounding the urethra is the corpus spongiosum. So when the corpora cavernosa fill up with blood, they obviously they inflate, and this inflation causes the penis to become erect. And the corpus spongiosum fills up with blood too, so this squeezes the urethra shut, and that's why it's impossible to have an erection and urinate at the same time. If we ask any male, it's almost impossible because the blood engorgement of the corpus spongiosum squeezes the urethra shut. Also, right after ejaculation, because of the ejaculatory reflex, um, the urinary bladder is the internal sphincter here is reflexively closed. It does not open, it does not allow urine to mix with semen, okay? Unless you have had prostate surgery done or if you're diabetic. So those are two people in which intermixing of urine with semen is a real possibility because their reflexes are damaged either due to prostate surgery or diabetic damage, okay? Impotence is also very common in diabetics. Okay, so what else do we, oh, all right, so some anatomy. The prostate gland is found right inferior to the urinary bladder. There's the urinary bladder. You can also see the ureters, which are coming down from the kidneys, bringing urine here, right? What else? Here's the rectum at the back, right behind the urinary bladder is the rectum and the anus. So here's the male reproductive system in an anterior view. Again, you see the two testicles suspended in the scrotum, right? Okay, so what's important in this view is something called the inguinal canal, which is this. The inguinal canal is a passage that allows entry of the abdominal contents into the scrotum, right? The inguinal canal is made up of the fascia or the surroundings of your oblique muscles, of your abdominal muscles. And what passes through this narrow canal in males is something called the spermatic cord. The spermatic cord contains what? The ductus deferens or the vas deferens, also the testicular artery and the testicular veins called the pampiniform plexus. All right, so all of those structures are passing here through the inguinal canal. So what is the importance of the inguinal canal? Inguinal hernia, which is way more common in males as compared to females, quite common, especially in males who lift heavy weights or have chronic cough, chronic constipation, or benign prostatic hyperplasia. Any condition that causes them to strain and to increase their intra-abdominal pressure can cause what? Their large intestine, their colon, to rupture out of its peritoneum and get entangled, trapped here within the inguinal canal. The worst case of inguinal hernia that I ever saw was in an 80-year-old male in the hospital. His scrotum that contains the testicles had grown to the size of a basketball-sized scrotum, because his intestines, his colon had literally ended up in his scrotum. All right, so let's make a note here. My 80-year-old inguinal hernia patient. So yes, and as I mentioned, since the inguinal canal is rather wide in males because it has to carry the spermatic cord, it's much more likely that inguinal hernia will happen in male individuals, okay? All right, so if you go back to these slides, they were all talking about these things. All right, so something else, the dartos reflex. Okay, that's an important one. So the dartos muscle is found within the scrotum. So what this muscle does is whenever the body feels cold, or if the insides of your thighs are stroked for a male, the dartos muscle contracts reflexively, thereby pushing the testicles closer to the body to prevent injury to them and to keep them warm. When the temperature gets hot, for example, when you have a fever, and that's what a lot of like old time people would tell you, that if a child is developing fever, a male child is developing a fever, one of the things to see is they, as they say, see if the balls have dropped, right? And that is literally true, because the dartos muscles basically relax when the abdominal temperature is high, thereby allowing the testicles to fall away from the body to maintain the temperature at a cooler level, so the sperm synthesis can take place. This is called the dartos or the cremasteric reflex, okay? Something to remember as well. Okay, then moving on. Okay, so we talked about, all right, so let's take a look at the inner histology of the uh, male testes. So here you have the testicle, and you see that each testicle is uh, divided into hundreds of these lobules, right, by means of collagenous fibrous tissue septum. It divides it into many different lobules. Each lobule contains these convoluted seminiferous tubules. These are the ones that make sperm. The sperm are made within these highly convoluted seminiferous tubules that you see inside of each testes, okay? And then you have this layer surrounding each testicle called the tunica albuginea. This is a tough fibrous layer inside of which you have another layer called the tunica vaginalis. Now this one has two layers, a parietal layer and a visceral layer, pretty much like the peritoneum, the pericardium that we've talked about before. In between the visceral and the parietal layers of the tunica vaginalis, you have the testicular fluid. So at this point, let's talk about two male conditions that you might have in this area. One is called hydrocele, which literally means a fluid in a cavity. The other one is called varicocele, okay? So let's talk about what those two conditions are. Hydrocele, either due to trauma to the testes, somebody got kicked in the groins or in that region, or fell from, or bicycle riding or horse riding, and any injury to the testicles. So this area in between the parietal and the visceral layers of the tunica vaginalis, it fills up with fluid. It's literally fluid around the testicles. And that's what a hydrocele is. Sometimes infections like mumps can give rise to it as well. certain viral infections, right? Usually it has no consequence, and with time, uh, the, the fluid subsides on its own. Okay, so that's hydrocele. So literally, uh, water, water in the test, water around the testicles. Okay, okay. Then what is a varicocele? Varicocele is when the veins that drain your testicles, called the pampiniform plexus, they get kinked, either because of some vigorous activity, some rough sexual act, or playing basketball or doing some acrobatics or whatever. Sometimes these pampiniform plexus, the veins draining the testicles, can get all kinked up. So the blood basically is blocked and it drains back into the testicles. And this could be painful. Uh, you tend to feel quite tender, and significant swelling takes place in the testicular region too. And this is characteristically when you palpate the testicles in such a situation, you feel what is called like kind of like a bag of worms feeling, right? When you palpate the testicles, it feels like a bag of worms. That's what we were taught. And actually, when I did palpate patients with that condition, that's exactly what it feels like, bag of worms, right? Because of the all the veins, kind of wormy veins, and they're filled up with blood. Uh, Now, varicocele needs to be fixed, because if you let it be, because of blood draining back into the testicles, it raises the temperature of the testicles. Infertility is quite a serious risk here at this point. So varicocele, you need to sometimes surgically uh, unkink the veins to reestablish the venous drainage from the testicles. So those two conditions, remember them, okay? So here you're looking at the testes under the microscope. This is what they look like. That is a seminiferous tubule where the sperm are made. So sperm are being made in different stages of maturation, as you can see. All right, two types of cells. Sustentacular cells here, also called the cells of Sertoli. These ones make sperm, all right, sperm makers, sustentacular cells. And then you have these cells on the periphery called the interstitial cells. These ones secrete testosterone. So remember, sustentacular cells nourish and support the sperm. The interstitial cells secrete testosterone. Okay, so something else to remember. Okay, so we talked about that, how the follicle stimulating hormone, or FSH, causes spermatogenesis in males, and luteinizing hormone causes testosterone secretion. Okay, all right. So what does testosterone, the male sex hormone, do? It stimulates the male sex drive, also the female sex drive, interestingly. So females who have low sex drive or libido, which, by the way, is the most commonly reported female sex desire disorder in psychiatric um, literature. It's called HSDD, for hypoactive sexual desire disorder. According to some statistics, anywhere from 30 to 40% of females across the population suffer from it. Okay, and so there's many different reasons for it, of course, like family pressures, juggling your career and your intimate relationships and all that. Sometimes there's an organic cause, like adrenal failure, adrenal burnout, or ovarian failure, either primary or secondary. All right, so in either case, how you treat it is by giving them testosterone, giving a female the male hormone, that, and the concentration of testosterone also rises at the time of ovulation. So females have more libido, more sex drive when they're ovulating, and that's because of testosterone, and not necessarily because of the female sex hormones, interestingly. Okay, so yeah, it causes like things like facial hair growth, body hair, chest hair, back hair, deeper voice, more muscle mass. All of those so-called male secondary sexual characteristics pick up under the influence of testosterone secretion. Okay. All right, so this is a good comparison between male and female gamete comparison. Okay, so in females, a single viable egg is produced. In males, 4 sperm are produced per cell. The female egg is arrested in meiosis before birth. The male sperm start uh, being made at the time of puberty. Females are only able to reproduce until menopause. I mentioned that one before. Males can produce viable sperm throughout their adult life, as we mentioned before. So here, these are the different stages of how an immature sperm basically Uh, it starts from these cells called the spermatogonia that turns into the primary spermatocyte. Then meiosis 1 happens, then they turn into the, and then meiosis 2, then they turn into secondary spermatocyte here, and then spermatids, which are still immature, and then till they grow a full-blown tail or a flagellum, now they are mature sperm. Now, the thing to remember is the first time when the cells become haploid, half the number of chromosomes, is when they turn from primary to secondary spermatocytes. This is the transition during meiosis 1, when uh, the number of chromosomes changes from diploid to haploid in the sperm. Okay, so the older the male, or the female for that matter, at the time of conception, the higher the chances of genetic anomalies in kids. In males specifically, if the male is over 45 years of age at the time that the sperm was contributed to the egg, uh, the chances of psychiatric disorders like bipolar disorder, autism, depression, look at the list, ADHD, schizophrenia, all of those go significantly higher. Interestingly, with the males, the father's advanced age, not necessarily the mother's age, that would be Down syndrome, right? So children born to males who were over 45 years of age at the time of conception, male children specifically, especially, have a higher chance of having these psychiatric problems, okay? So STDs, next up we are looking at sexually transmitted diseases, all right? And they are, uh, recent statistics from CDC have shown, CDC, let's say recent CDC statistics on STDs. Or you would expect with all the sex education and common knowledge and education, uh, the STD incidence would be going down. It's quite the contrary. We have had more STD cases recently than ever before, okay? Uh, and they're coming back in more drug-resistant forms, more mutated, more pesky forms, all right? And STDs, as we see here, are a major cause of pelvic inflammatory disease in females that can cause permanent like infertility in them, okay? So STDs, or sexually transmitted infections, are divided into bacterial, viral, and parasitic, okay? There are some fungal ones too, but they're kind of rare, at least in immunocompetent individuals. Let's start with the bacterial ones first. The most common bacterial STD across the world is chlamydia. It's caused by a bacterium called Chlamydia trachomatis, as you can see here. Uh, Approximately 40 million people, teens, adults, even elderly, are afflicted with it. And the thing about chlamydia is a full 1/3 to 2/3 of the cases are asymptomatic. They don't even know they have the disease. And that's what makes it so dangerous. They're spreading it and contracting it from others. They don't know they have it, okay? But when they do have symptoms, things like vague symptoms like painful discharge, vaginal or penile discharge, the good news, it is treatable with antibiotics. And it's one of those infections that can be passed on to the children as well, to the unborn child. So it is a congenital infection as well. Okay, next up in bacterial infections is gonorrhea. This is caused by a gram-negative bacterium called Neisseria gonorrhoeae, again, bacterial, and it's coming back with a vengeance as well. We are seeing more and more antibiotic-resistant strains coming back now, okay? And this can unfortunately also be passed from mother to the unborn child at the time of birth. The third bacterial STD, syphilis, caused by the spirochete bacterium Treponema pallidum, as you can see here. And now this we thought was a thing of the medieval times. It was a medieval Middle Ages disease. It's back. And again, in more virulent antibiotic resistant forms now, okay? And syphilis basically occurs in 3 different stages. Primary syphilis, which is the initial stage, you develop a painless sore called a chancre on your genitals, basically, and it tends to resolve on its own. After about 2 weeks, you think everything is fine. It's not. The bacterium is continuing to multiply and divide in your system unchecked. And then you break out after a few months with secondary syphilis. Now you have a body-wide rash, including the palms of the hands and the soles of the feet. And then if still untreated, then you go on to the tertiary stage, which is the most serious. At this point, you develop things like what are called gummas, lesions called gummas, right? In, see, tertiary syphilis, gummas, and So what are these? These are necrotic lesions of the skin. The skin literally starts to break down with pustules, and it's breaking down. So these develop during tertiary syphilis, all right? Kind of like what leprosy looks like. Um, so, and not only that, but cardiovascular and central nervous system damage occurs. It could be lethal if untreated. So as for your viral STDs, genital herpes, the second most common STD overall. The most common sexual STD, sexually transmitted infection of all is human papillomavirus, HPV. That's the highest. And HPV is a risk factor for what? For developing cervical cancer, especially strain 16 and 18, as we mentioned, right? Then it's followed closely by genital herpes that causes painful blisters on the genitalia. This could be, you cannot get rid of viruses, but you can control their replication. See, and this is the thing that we talk about vaccines for COVID-19 and for whatnot, right? Now, the question is, how do you kill something which is not living in the first place? How do you even eliminate a biological entity that is little more than a bunch of DNA or RNA packed in a protein code whose only sole reason for existence is to find a host, infect it, and replicate within and move on? It's impossible. There's no way that you can completely wipe out viruses. You might be thinking of, there are only two viruses in history that have purportedly been wiped out, right? So what are those? Smallpox in humans, the virus that killed and maimed more humans than any in history, upwards of 500 million people, and then the rinderpest virus, which was found in cattle. Actually, thankfully, it was not a human virus. These are the only two viruses that have been successfully eradicated in the human population. For smallpox, the last known case outbreak was back in 1977 in Somalia. No other recorded human cases have been recorded in recent history. But smallpox is still there in highly guarded military facilities, research facilities, both in America, in the United States, and in Russia. So it's not technically extinct, and there's always a danger of somebody having access to the smallpox virus and using it as a bioweapon and bioterrorism and whatnot, right? So but here's the thing, smallpox, the only known host and reservoir for that virus was humans. It came from animals. It's a zoonotic virus, like almost all other viruses. It came from a rodent species 40 million years ago. But since uh, it was only confined to humans, you could vaccinate your way out of it. You could vaccinate it to extinction, right? Reasons for smallpox and rinderpest elimination. But here's the thing, think COVID-19. We don't even know still where it came from in the first place. Most likely from some horseshoe bat populations in Western China, but we don't know for sure, right? But one thing we do know, coronaviruses have many hosts, not only humans. They can infect pigs, they can infect horses, they can infect dogs, they can infect cats, they can infect civets, they can infect bats, all kinds of creatures. So if you eliminate it in the human population, guess what? It's still mutating and thriving in some other species. Sooner or later, it's going to spill over into humans again, right? So it's impossible to completely eradicate viruses. What we can do is strengthen our own immune systems, sensible eating, exercise, quarantine measures, not touching our face, and all of those things. And if even if you get infected, if you're healthy overall, you would most likely overcome these viruses and develop lifelong immunity against them, active immunity. Vaccines are not a magical cure, certainly not for people over 65 years of age. Even if you vaccinate them at 65 years of age and higher, your immune system is not even responding to the vaccine that much. You're not going to develop all those antibodies. It's not going to be a robust response. In some people, it's going to be too much of a response, and they can end up with a cytokine storm and blood clots, such as what we are seeing with the Johnson and Johnson vaccine, right? That's a hyperreaction, blood clots forming there. So, uh, so some things to ponder, right? Vaccinations in the elderly, uh, limited response, right? Hyperimmune reactions to vaccines, right? Like the Johnson and Johnson vaccine, which has been paused here in the United States following many reports of blood clots, right? Uh, um, and there's even a term for this now. It's called VITT, VIT, for vaccine-induced thrombotic thrombocytopenia. That's what it's doing, right? It is causing thrombocytopenia. It is causing our platelets to basically become hyperactive in the venous sinuses of the brain. So all the platelets are gathering in the brain, causing blood clots, while there is a lack of platelets elsewhere. So you're bleeding all over the body, but you're clotting in the brain. That's what it is, okay? All right, so how does the scrotum help regulate the temperature of the testes? Causes the testes to be suspended outside of the abdominal cavity, keeps them cooler. What are the major cell types in the seminiferous tubules? The interstitial cells and the sustentacular cells. What hormones are produced by the interstitial cells? Testosterone. And the sustentacular cells, so they make sperm. Okay. And sustentacular cells also secrete the hormone inhibin. Inhibin inhibits the oversecretion of testosterone and the over-manufacture of sperm. Okay. How does a spermatogonium divide to produce spermatozoa? From spermatogonium to primary spermatocyte, then secondary spermatocyte, then spermatids, and then sperm. What main events occur in spermiogenesis? We just mentioned those. All right. So here, okay. So we talked about the male reproductive tract before, right? So you should be able to recognize all of. So first up, here's the urinary bladder, the ureters coming to the urinary bladder. Those are the seminal vesicles, right? Accessory sex glands that produce fructose and prostaglandins. Prostate, which secretes seminal plasmin, citric acid, and PSA. Here is, all right, so then the testes, right? Each one has seminiferous tubules in them. Epididymis, then the ductus deferens or the vas deferens. It turns over the ureters here. So the seminal vesicle sends a tube to the ductus deferens. Now it's called the ejaculatory tube or ejaculatory duct, which passes through the prostate. This is called the prostatic part of the urethra, the male urethra. So here are your pair of Cooper's glands or bulbourethral glands that secrete an alkaline mucus. Here are your superficial perineal transverse, the urogenital muscle diaphragm, right? So this part of the male urethra, which passes through the urogenital diaphragm, is called the membranous urethra. And then the longest length of urethra that passes through the entire length of the penis is called the spongy urethra. Why the spongy urethra? It's surrounded by the spongy corpora cavernosa, these on the two sides, and the corpus spongiosum. Corpora cavernosa are superior or dorsal, and the corpus spongiosum is inferior or ventral. So semen, what is it? 99% water with sperm and some contributions from the accessory sex glands, which are in males, seminal vesicles, prostate gland, and bulbourethral glands. What do seminal vesicles do? We talked about that. Fructose and prostaglandins, alkaline fluid. Prostate gland, again, we talked about that one too. PSA, seminal plasmin, and citric acid. Three secretions from there. Bulbourethral glands secrete an alkaline mucus. Again, we mentioned it, right? So an average ejaculate in a healthy adult male, anywhere from 200 to 500 million sperm in there, okay? BPH, benign prostatic hyperplasia, very common condition. 60% of 60-year-olds, 70% of 70-year-olds, and 80% of 80-year-olds have some degree of benign prostatic hyperplasia and even prostate cancer. Okay, so why is it not cause for major concern? Because most cases of prostate cancer are very slow growing. They can take anywhere upwards of 30 to 40 years to fully disseminate and stuff. Most males would not live 30 or 40 years after they've already hit 80 years of age. So therefore, But some prostate cancers, a minority, about 5% are highly aggressive and they need to be treated. So what happens in benign prostatic hyperplasia? This is not cancer, this is benign overgrowth of the male prostate. The prostate grows with age and it kinks, the urethra, problems with urination, weak stream, dribbling, this feeling of not completely voiding the bladder, nocturia, waking up multiple times at night to urinate, and pain during urination, something called dysuria. So you see all of that, right? It can be treated with drugs, or you can surgically remove the parts of the prostate as well. Prostate cancer, the most common malignancy in males over 50 years of age. Not all of them are equally aggressive though. You can pick them up via digital rectal exam, which I mentioned before. You can look at a PSA level as well. Treatment is radiation therapy or surgical removal. All right. Uh, the male penis, very similar to the clitoris in females. Those are the two corpora cavernosa, the spongy bodies. Here is the corpus spongiosum. They fill up with blood when the male is sexually excited, causing an erection, right? And uh, and again, the two muscles involved here are your what? The bulbospongiosus muscle for ejaculation and complete voiding of the bladder, and the ischiocavernosus muscle, which is involved with erection. This is an uncircumcised penis versus circumcised one. Circumcision. Uh, most people, most medical personnel advocate for it because circumcision, circumcised males have a 30 to 40% lower chance of contracting STDs, including HIV. Okay. All right. So here you're looking at a cross section of the penis, corpora cavernosa dorsally, corpus spongiosum ventrally. Here's the urethra, the spongy urethra passing through. Those are the arteries and the veins of the penis. Okay, male sexual response, same 3 cycles, very similar to the female one. Excitement phase, sexual thoughts, sexual stimuli, sexual situations cause the heart rate to go up, breathing rate increases, blood pressure increases, blood flows to the genitals, causing erection of the penis, all right? And then orgasm, again, an explosion of dopamine and oxytocin in the brain, extremely pleasurable sensations, coupled with ejaculation here in males. The ejaculation reflex ensures that the internal urinary sphincter is closed, shut off, so there's no chance of contamination of semen with urine, okay? And then the resolution phase, everything goes back to normal. It's all peaceful and quiet again, followed by a refractory period, which means you cannot get an erection and an ejaculation again. And this time frame increases with age. As you get older, the male gets older, the refractory period gets longer and longer. Okay, sequence of ducts through which the male gametes pass from the testes to the epididymis to the ductus deferens to the ejaculatory duct to the prostatic urethra to the membranous urethra to the spongy urethra and out. What are the specific functions of the accessory glands? Know what each one does, what prostate, seminal vesicles, and bulbourethral glands do. How is seminal fluid different from semen? Seminal fluid is simply water and sperm. Semen has also contributions from the accessory sex glands. What are the similarities and differences between corpora cavernosa and corpus spongiosum? Similarity, both are spongy tissues that fill up with blood during sexual excitement. Corpora cavernosa are two couple of erectile bodies on top of the urethra. Corpus spongiosum is a single body surrounding the spongy urethra. How do erection and ejaculation differ? Erection is a parasympathetic phenomenon. Your parasympathetic rest and digest nervous system oversees it. Ejaculation is a sympathetic response. That's your fight or flight mechanism. All right, so I am going to stop here on slide 178, looking back at the schedule. We'll have the remainder of of chapter 28 next week. I'll send that recording to you along with the last chapter, which is about pregnancy and genetics, chapter 29. All right, so do not forget to take your test, your lecture exam number 3. Keep those lecture quizzes on Connect and your case studies in mind as well. Lab practicals, the lab work that I've sent out, keep up with it. Any suggestions, feedback, comments, you have my email address, feel free to let me know. Enjoy the rest of your day, rest of the weekend, and hopefully I'll see you all virtually next week. So till then, take care. Bye-bye.